we're going to talk about the hierarchy of oxygen delivery. Now, we've got a great cheat sheet about this, so make sure you check that out. But we just wanted to create a little video for you guys to help you understand the basics and the best ways to remember these things. So let's talk about these devices in order from least invasive to most invasive. When you're administering oxygen to your patient, you always want to start with the least invasive method and move to more invasive methods if they're required. So it starts at room air. This is basically no device. And then from there, you'll see the devices get bigger and bigger as you move along. So first we would move to a nasal cannula, which is this. And then from there, we'll go to a simple mask and then to a Venturi mask. And if that's still not working, even though the Venturi gives us a little bit better control, we'll move to a non-rebreather, which is what you see here. Remember, the non-rebreather has the bag attached to it. And then at that point, if your patient's really struggling enough to need a non-rebreather, you need to make sure you call the respiratory therapist, get somebody else involved because this is a significant problem. Now, one of the other things we can do is non-invasive ventilation, and the two options for that are going to be CPAP and BiPAP. So CPAP is continuous positive airway pressure, and BiPAP stands for bi-level positive airway pressure. And then from there, if needed, we're going to move to invasive ventilation, either through an endotracheal tube or a tracheostomy. And then if they do have a tracheostomy, we can wean down to a trach collar, which is essentially a mask that goes over the trach, or a T-piece that offers blow-by of oxygen. So one of the most important things to know about the device that you're using is what kind of FiO2 you can get. Now, FiO2 stands for fraction of inspired oxygen, and essentially it's the percentage of the air inhaled that's actually made up of oxygen. We know room air is 21% oxygen. The rest of it is hydrogen and nitrogen and other gases. So our bodies can normally function easily on 21% oxygen. Now, the cheat sheet will show you the exact numbers, but we want to give you a quick way to remember these. So when we apply a nasal cannula, we start at 1 liter per minute, which is 24%. Okay. If you can remember this, and then you can remember that it goes up by 4% from there, so 28, 32, 36, etc., then you'll always know what it is. So it starts at 24 and it goes up by 4% at a time. Now with a nasal cannula, we cannot go past 6 liters per minute. At that point, the flow is just so high in their nose, the oxygen just stirs up and comes right back out. So once you hit 6 liters per minute, which is 44% oxygen, you're going to need to move up to a simple mask. Now with a simple mask, the FiO2 at 5 liters is the same as what it is for a nasal cannula. Nasal cannula, 5 liters is 40%. Okay. So it's the same. When you go up from there, you're going up about 5 to 7 liters per minute above that. So 5 liters per minute is the same, and up about 5 to 7% from there. So this allows us to get more FiO2 into the patient than we would be able to get with a simple nasal cannula. Now, the next thing that we would use after a nasal cannula and after a simple mask is also a Venturi mask. Now, Venturi masks, the benefit of that over a simple mask is that we have more precise control. And so we could get anywhere from 24 to 80% depending on the attachment. Now, this image is of a humidifier for a trach collar, but this is what your attachment's going to look like, something like this. As you spin this attachment, you're going to choose the FiO2 that you want, 35, 40, 60, 80, and it's going to tell you if you want 80%, you're going to have to run it at 10 liters per minute. So based on what your attachment says, you're going to put that specific flow rate onto the oximeter so that you know you're getting what you need. Now, the next thing from a Venturi mask would be a non-rebreather. Essentially, you're getting 10% per liter per minute. So 10 liters per minute is about 100%. We can't get it exact because it sometimes pulls air in around the mask, but it's pretty close. Now, yes, you could put a non-rebreather on your patient at 6 liters per minute, and it would be 60% FiO2. But let me tell you, if you're headed to a non-rebreather, it's because your patient's going downhill. You need to put it on, plug it in, and crank it to 10 because something's not right. Now, One thing to note here is that you do need an order for whatever device you're using. You may change devices for the safety of your patient, but then you need to call the provider and get the order updated. Now, some facilities will have standing orders that allow respiratory therapists to advance these devices as needed. So just make sure you're collaborating with them and you know what your facility policy is. So let's talk about the difference between CPAP and BiPAP. Both of these are forms of non-invasive ventilation, and it's done through a mask like this one that you see in the picture. So CPAP stands for continuous positive airway pressure, and essentially it's giving them positive pressure throughout their entire breath, all at the same level. So the pressure waveform looks like this. The reason we do this is it helps to keep the alveoli open and it decreases work of breathing. So it makes it just a little bit easier, gives them a little bit support, and it helps to open up those alveoli. Now, BiPAP stands for bi-level positive airway pressure, and it's just by the name, you could tell it's positive airway pressure at 2 levels. So there's a level of pressure called the inspiratory positive airway pressure, or IPAP, and then there's the positive end expiratory pressure, or PEEP. So what we do is we see inspiratory pressure, expiratory pressure, inspiratory pressure, expiratory pressure. And what we do with that PEEP is if this is 0, the PEEP is just above 0, maybe 5, maybe 7, and that just helps to keep the alveoli open even after expiration. And the big benefit of BiPAP over CPAP is just its extra support for that inspiratory pressure. You're going to get more pressure on inspiration, so it's going to help improve any kind of work of breathing issues. Okay. Now, after these two, if we need to, we're going to have to move to invasive mechanical ventilation. Now, we'll talk a little bit more about that in the vent alarms lesson, but for now, just know that that would be the next step. So just to recap, we always start with the least invasive device and we work our way up as needed to support our patient, depending on what their needs are. We know that by monitoring their SpO2, right? Make sure that you're collaborating with your provider or your respiratory therapist, especially if you're having to advance to higher devices and if your patient's oxygen requirements are going up. And then finally, be sure to know where you are when it comes to FiO2. If you have a patient who is on 4 liters nasal cannula, you have to know that that's 36% to know if I need to go up from here, where do I go? So knowing where you are helps you know where you can go. We want you guys to be on top of it and be level-headed if your patient starts to go downhill because you know exactly what to do next. So don't forget to check out the cheat sheet attached to this lesson. You can even print it out and take it with you. Or there's a similar card in the scrub sheets that'll fit right in your pocket. Now go out and be your best selves today. And as always, happy nursing.